Good evening, everyone. I listened to my previous video because it took forever to load, and I apologize for all the scratchy noise. So listen to this one instead. My name is Christina, and I will be presenting a case of a 45-year-old Asian male who presents to the clinic for evaluation of left knee pain. Patient arrives alone, and he is a reliable historian. Initial we will use for him is AB. Okay. So the patient states this is his chief complaint. My left knee has been hurting for the past week after jogging. So HPI, the pain started gradually about a week ago. He reports that it is localized to the anterior of his left knee. He describes this pain as dull and achy. He also reports mild swelling and occasional stiffness on his left knee, especially after prolonged sitting or after an activity. He reports the pain worsens with walking up and down the stairs, prolonged standing, and jogging. And he does report improvement with rest, ice, and ibuprofen. He denies any locking, clicking, or giving away of the knee. There is no history of trauma or injury. He rates the pain 5 out of 10 at worst and 2 out of 10 at rest. His past medical history includes hypertension, which he manages with lifestyle modifications, and he is slightly overweight. His only medication is the ibuprofen. He did not tell me his dose. He denies any allergies. Family history includes on the father's side hypertension and type 2 diabetes. His father is deceased at the age of 70. Mother is alive, age 68, with a medical history of hypertension and osteoarthritis. Social history, he did report that he has a sedentary office job. He tries to do regular jogging, and he is trying to maintain a well-balanced diet, but he does report occasional fast food consumption. He denies any tobacco use or any illicit drug use or recreational drug use. He did report occasional alcohol consumption during social events. On his review of systems, he denies any fever, chills, or fatigue, denies any chest pain, palpitations, denies shortness of breath. He denies numbness, tingling, or weakness in his extremities. He does report left knee pain with mild swelling, but he denies any warmth or redness or instability. So for his on the physical exam, his vital signs were stable with a blood pressure of 128/78. BMI is 27.3. That classifies him as overweight. And musculoskeletal examination, it does reveal mild swelling of the left anterior knee. No deformities or bruising noted. On palpation, he did report there was mild tenderness over the patellar tendon and a medial joint in the medial joint line, with no significant effusion or warmth. Range of motion is full, passive, and active, but he does report mild discomfort on full extension. Special tests were also performed. Lockman and McMurray's tests were negative. Therefore, we ruled out ligamentous and meniscal injuries. However, the patellar grind test was positive suggesting a patellofemoral pain syndrome. So based on his history, my exam findings, and the positive patellar grind test, my primary diagnosis would be patellofemoral pain syndrome. It's also known as runner's knee. It's consistent with overuse and then also with recent increased jogging. My differential diagnosis would be patellar tendonitis. This is less likely because the pain is not sharply localized to the patellar tendon. Another differential diagnosis I came up with is meniscal tear, but there's no history of trauma, twisting injury, or mechanical symptoms like locking or catching. Another possible differential diagnosis would be osteoarthritis of the knee, just because of the given family history on his mother's side, but it's unlikely due to the due to the acute nature of his symptoms. So for my plan is going to include both diagnostic and therapeutic interventions. So first we want to x-ray that left knee to obtain so we can obtain and to assess for patellar malalignment or osteoarthritis. If symptoms persist, then we can order an MRI can be considered. For pharmacologic management, we'll include naproxen 500 milligrams twice daily as needed for pain and inflammation. And then patient can also take Tylenol or acetaminophen as an alternative if NSAIDs are not tolerated. And then, of course, non-pharmacologic treatment will focus on the activity modification. So we'll let him know, educate to avoid jogging, instead switch to low impact exercises like swimming or cycling. We need to do some ice therapy at least 3 to 4 times daily, 20 minutes at a time, and then a structured quadricep strengthening program. It includes straight leg raises and terminal knee extensions. Therefore, we'll refer him to physical therapy for patellofemoral rehab. And then we can also suggest a knee brace or a patellar taping that can help with his symptoms, just to prevent that the tracking. We will we'll let him know to follow up in 4 weeks, to schedule a follow-up appointment in 4 weeks so we can reassess his symptoms and see if there's any improvement. If there's still pain, then we can consider an MRI and maybe an orthopedic specialist can be also considered. All right, thank you, and I'm happy to answer any questions.